5, 4, 3, 2, 1. We are live now.
So, a very good evening to all again. So, on behalf of Young Surgeon Forum YSF and Maharashtra Orthopaedic Association MOA, I welcome you all for this 19th episode of this series. So, the brainchild of Dr. Wasudeo Gadegone, MOA President, along with OrthoTV, we have started this initiative almost now from 6 months. We do have previously 18 episodes with various institutions from all across India. We are very fortunate to have Ahmednagar Orthopaedic Association as a guest society for this today's session. Dr. N Deshpande from Ahmednagar, who will be the moderating for this today's session. Dr. Prakash Sigedar, Dr. Sandeep Biraris, and Dr. Girish Motwani are also associated for this today's session. We do have young dynamic 6 young orthopedic surgeons from Ahmednagar who will be presenting their cases. As originally conceptualized, like to give opportunity to the young orthopedic surgeons to showcase their work on this global platform. So again, I welcome you all on behalf of MOA and Young Surgeon Forum for this session. So without much further ado, I request our moderator for this today's session, Dr. N Deshpande, along with Dr. Girish Motwani, who is the coordinating for this today's session, to start the proceedings. He will be briefly introducing the speakers and then we will move ahead with the first case.
Yeah, good evening everybody. At the outset, I thank Dr. Gadegone sir, Dr. Karne sir, President-elect Dr. Ahmednagar and the entire executive body. And I also thank Dr. Manoj Pahukar, Girish Motwani, Sandeep Biraris, Prakash Sigedar and all the stalwarts of the Maharashtra Orthopaedic Association. I thank for 2 reasons. One is for starting this Young Surgeons Forum so that we have a next generation of orthopedic surgeons who would be dynamically interested and actively involved in academics. And secondly, I also thank for giving the Orthopaedic Association of Ahmednagar opportunity to present their work. So with this brief let me introduce something about the Ahmednagar Orthopaedic Association. Our president is Dr. Prabhas Patil, who would be joining soon. I request meanwhile Dr. Rahul Pandit to call him and ask him to join our president, Dr. Prabhas Patil. Dr. Rahul Pandit is our secretary and we recently had a best chapter award at Goa conference, IOA conference, and Ahmednagar Orthopaedic Association is doing really good work and we are actively involved in all MOA and IOA activities. We follow one principle in Ahmednagar that we all are colleagues and we are not competitors of each other. And therefore, we all have a really cordial, friendly and brotherly relations with each other, ready to help amongst ourselves by any means. So with this, I introduce my young team. We will be presenting Dr. Nitin Varpe as an opening batsman, who will be followed by Dr. Ghanwat, and then I'll be inviting Dr. Mandar Bhosale. Then I'll invite Dr. Ashutosh Joshi, and then I'll invite Dr. Dinesh Patole, and Dr. Rahul Pandit is kept as a last. This order is decided because of the ascending order, because first 3 speakers will be speaking about the ankle, and then the second 2 speakers will be talking around the hip. One will be talking around the neck of the femur and second person will be talking about the acetabulum. And Rahul Pandit, who is a spine surgeon, he is a dynamic surgeon who does everything, and he has selected spine as his today's case for presentation. So the last case would be a spine case. So it's a mixed bag of complex cases. And let me call upon Dr. Nitin Varpe to present his work first. Dr. Nitin, please share your screen.
Yes. Good evening, respected teachers, my seniors, my friends. I am first of all thankful for all the YSF team and Ahmednagar Association and specifically Dr. N Deshpande sir and Rahul Pandit sir for giving me the opportunity. Today I'm presenting my case experience of heel pad avulsion. Everybody is listening to me, able to get my sound? Hello?
Yes.
Yes. Presenting my case experience of heel pad avulsion. Hence, the title of my case presentation is the anchorage of the partial heel pad avulsion with the use of multiple Karne wires. The history of he was a 17-year-old male patient, had a history of road traffic accident and encountered a blunt trauma to the foot. No other injury was there for that patient and presented with a bleeding wound of the foot. These are the clinical visuals of the wound. Now you can see there is a tangential force might have disturbed this all soft tissue medially, laterally, and from the posteriorly, leaving breach anteriorly. This is the partial heel pad avulsion. The flap was viable, sensations were present, and the wound was quite contaminated. And there was no evidence of calcaneal fracture or T rupture. So the options. Anybody want to comment on the options? Anybody can suggest me any options? Can go ahead with experience.
Nitin, I exactly follow what you have done. I anchor the heel pad with the help of K wires. Of course, I see whether the skin flap is viable first by help of needle prick and all.
Yes, sir.
And,
Anybody
what-
using sutures only? Repairing heel pad avulsion with sutures only.
if we put only sutures, there is a load on the suture, and there is a likely chance that the heel pad may not get adhered or attached to
Yes,
the
sir.
calcaneus bone.
Yeah, so I think the basic vascularity of this heel pad, which is very important.
Yes, sir.
How do you manage that cavity which is there inside, either with a closed negative drain or sometimes can be
Yes,
put a
that is I want to highlight these points. Many people are putting the negative pressure wound therapy for this, putting drain and after repairing so that there will no build-up of the wound pressure. There is no necrosis and there is no chances of the wound dehiscence or failures. So sutures only will not going to help. That's why I decided to either sutures with KYS. Then I gone through the literature and there was a very interesting article. So I followed what I done in this case. I done the copy, given the copies wound lavage. As everybody knows, heel injuries or heel pad avulsions are most of the times are contaminated. So I given proper debridement copies wound lavage. And once I noticed heel pad is viable, so my principle was in my mind was to reattach the heel pad to the calcaneus. So I put the multiple K wires that 1.8 mm. Initial wires, my purpose was to secure the avulsed heel pad in the anatomical positions, and subsequent K wires I used just to secure my fixations. So, and in that what I used was keeping distance of around 1.5 to 2 centimeter apart from each other and as well apart from the wound edges. And before coming to the rationale, I will highlight the blood supply of the heel pad. There is a blood supply from the posterior tibial artery and the peroneal artery that giving the calcaneal branches. Now you can see in this photograph, these branches are coming, giving huge anastomosis at subdermal level as well as the periosteal level of the calcaneus. And these the anastomosis travel through the fibrous septa of the tissue which adheres the flap to the calcaneus. So vascularity is very much important in the case of wound in the heel pads. So what I done and that rationale was that just to, if you put the heel pad securely to the calcaneus without disturbing the anastomosis, it is very high chances of success. So rich vascular anastomosis among these vessels at subdermal as well as periosteal level. These vessels travel within the fibrous septa. That fibrous septa is a very unique structure. That is a honeycomb structure which tied the fat cells, and which unique structure give high tensile strength to the heel pad. So simple reattachment without disturbing the anastomosis will keep the viability of the flap and give very high success rate. and K wires giving very least to the flap. If we use the sutures, that will injure the flap, that will injure the vascular anastomosis. And the advantage of this technique is technically very less demanding. It's very simple, cost effective. And these are the follow-up of my case. These first images after 6 weeks, and these are the latest photograph around 7 months after the injury. That all heel pad healed very well. And in 2012, JBJ's 4 cases were reported with very successful outcome. In this case, the partial heel pad avulsion was reattached with help of only K wires. There was no use of any sutures. And in my case, the take-home message is, in any heel pad injuries are technically contaminated. So debridement is very, very important. Proper debridement, thorough debridement, wound wash, copious saline wash, and this stable reattachment of the heel pad to the bone without disturbing the vascular anastomosis. And every attempt should be made to retain the original tissue, because this heel structure is very unique. You cannot replace with any flap, rotational flap, free flap, because that structure cannot be replaceable. It will be technically inferior to the original heel pad structures. And the technique I use is simple, effective, reproducible. So I personally doing the only K wires without sutures in every case of partial viable heel pad avulsions. Thank you.
Thank you, Nitin, for a wonderful presentation, and you were really very informative for all of us. Has anybody got any question to Nitin?
Yeah. I think, I would like to ask one question. Nitin, can you stop sharing your screen?
Yes.
So how do you define, like, for all the general orthopedic surgeons, like how will you diagnose it as a partial heel injury, and what do you control at the first day for that patient related that this will be a viable kind of plantar flap, or it will go into necrosis? Are there any parameters on the day one where you can judge?
You can see the sensations of the flap. If sensations are present, there is active bleeding. And if there is a breach, most of the time in partial heel pad avulsion, the lateral disruption of the soft tissue, medial disruption posterior, and there is a hinge on the anterior side. So we can see the sensations. So if the sensations are present and there is active bleeding, on the day one it is quite a bit difficult. But partial heel pad avulsion, if you use the biology, if you respect the biology, chances of survival of the flap is very high.
Okay.
Nitin, my question is, how you take care of vascularity while putting the K wires? Like
putting K wires 2 centimeter apart from each other and 2 centimeters away from the edge of the wound. So anastomosis is mainly at the subdermal level and at the periosteal level. So if we do the K wires away from the edge and away from each other, you will hardly disturb the anastomosis of the heel pad.
Girish, do you have any inputs for this case? You do a lot of this foot and ankle work.
Yes. So, this is fixation of the heel pad with the K wire is a known strategy of the fixation. In fact, it's a very good strategy, and we used to fix many times when you have a complete avulsion of the heel pad, even up to the forefoot skin. Most of the time we use the K wires to fix the heel pad because it is thick, so it has a hold like a cancellous bone heel pad. Also, because the calcaneum is a completely cancellous bone, so as long as it is not infected, the take-up is very good. And on the top of the K wires, even if you apply the VAC, it helps in the healing of the avulsion injury very early. And majority of the time they present very late. So, challenge is a big. So that's why we used to use the adjuvant VAC therapy in association with the K wire fixation. It's really a good technique. And no suture, it is very important. No suture on day one.
Thank you, Girish. Now, may I call upon Dr. Vikrant Ghanwat to present his work? Vikrant, start sharing your screen.
Yes, sir. I take this opportunity to thank, first of all, Maharashtra Orthopaedic Association for giving us this platform to present our work. As we are practicing in a rural area, rural parts of Ahmednagar, I am very much thankful to MOA, Dr. Gadegone sir, and all the office bearers for giving me this opportunity. Today, I will be presenting a case of bilateral pylon fracture in a young adult. So he is a 20-year-old patient presented to us complaining of severe pain, deformity, swelling at the both legs. He was unable to stand or move his legs. There was a pain at back also. He had a history of fall from an electric pole due to electric shock. So on examination, he was conscious, oriented, and vitals were stable. Right ankle was showing varus deformity. There was 3+ swelling, and tenderness also was 3+. On left side, there was swelling also. Swelling was 2+, and tenderness was 3+. There was tenderness at dorsal spine. There was no neurovascular deficit. There was exit wound at left thigh, which was 2 by 1 centimeter. We did his X-rays. This is right side X-ray, which shows a very displaced pylon fracture with articular involvement. Almost more than 30% of the articular surface is involved. It is, and there is a lot of metaphyseal comminution also. So it is Rudy Algor type 3, or we can call AOA 43 type 3B for this injury. On left side, there was little less severe injury. There was pylon fracture, but it was not displaced. We can also call this as a trimalleolar fracture. It is Rudy Algor type 1 or AOA 43 type A injury. There was a D8 compression fracture, which was stable, and there was no neurodeficit. We did CT of his right ankle. You can see in the coronal cuts, there was a lot of metaphyseal impaction on the medial side. There was comminution on lateral and medial aspect also. In sagittal cuts, you can see there is a lot of comminution anteriorly. In axial cuts, you can see the 4 fragments here. This is the anterolateral fragment, or you can call as a choput fragment. This is anteromedial, or this is posterolateral fragment, and this is the central depressed articular portion. This is the 3D CT. So patient was stabilized. Both legs were put in slab and elevated. Patient taken for surgery on the same day. Injury to surgery interval was approximately 7 to 8 hours. On right side, there was very tight swelling, and there was blisters also. So we took decision of doing right side in 2 stages. First, we did close reduction of the right side fracture and did ankle spanning external fixator. On left side, there was not much swelling. The skin was good. So we did primary fixation on left side. So this was post application of fixator on right side. You can see there is articular impaction here. This is post-op on left side. So
sorry to interrupt, Vikrant.
Yes, sir.
When did you intervene on right side? Which day?
On same day, sir.
No. Left side you operated same day.
Yeah.
Right side you spanned
right
it. I mean, you
on same day
fixed it.
We applied fixator.
Yeah. So
We
and
applied
after
fixator.
Yes. Then after fixation, how long it took for you to intervene primary?
5 days, sir.
Definitive
I am
fixation.
presenting afterwards, sir.
Okay.
So this was on
proceed
left
with the
side.
left. Sorry to interrupt you.
We did a lateral plate fixation for the lateral malleolus, cancellous screw, 4.5 mm cancellous screw for middle malleolus, and percutaneous 4.5 mm cancellous screw was used for the posterior malleolus. After surgery, Patient went in pulmonary embolism. He was managed with positive pressure ventilation and low molecular weight heparin. After 5 days in ICU, we took him for definitive fixation on right side, as he was stable and the skin condition was good. On right side, we did fibula open reduction and internal fixation with lateral anatomical locking plate. The anteromedial approach was taken for a pylon articular reduction. We used 3.5 Ellis plate for the reduction of anterior pylon fragment. The medial malleus was fixed with 4.5 mm cancellous screws. There was a lot of comminution present medially. So these are the intra pictures. You can see the lateral locking plate for fibula interfract screw. This is Ellis plate, which is used to buttress the anterior part of the pylon. And these are the CCs. In this area, there was a lot of combination. It was very difficult to put these screws. This is immediate post-op X-ray of right side. In lateral view, we can see there is nice buttressing of the anterior fragment, and the articular margin is well maintained. The AP view is not exactly AP, it is a little oblique, so we can see this thing here. The patient was put in below knee slab for 6 weeks. After 6 weeks, we removed slab and range of motion exercises were started. Partial weight bearing started at 8 weeks. Full weight bearing started at 3 months. This is X-ray at 3 months follow-up. Patient is walking without support at the 3 months. We can see good union of fracture on both lateral and medial side, and anterior side also. This is 3 months post-op on the left side. This is gait of patient at 3 months post-op. Patient is followed up for 6 months. This is X-ray out of right side at 6 months. You can see very much good consolidation of the comminuted area on medial side and anteriorly also. This is on left side, 6 months follow. Patient is able to squat at 6 months. This is a range of motion at 6 months. This is gait at 6 months. Thank you.
Thank you, Vikrant, for your nice presentation again. I'm sure there are a lot of queries, so I would request Dr. Girish Motwani to begin his comments, because he is also doing a lot of foot and ankle work. Girish, do you feel this was properly addressed?
Hello.
Girish. Is Girish around?
Yeah. Can you stop sharing? We can have the comment.
Yes.
Yeah. Dr. Girish Motwani, please.
I think if he's not around, yeah. I think I will take one question, like on the left side. What is the cause of pulmonary embolism? It seems to be a fall from typical injuries.
High energy trauma, sir. It was fall from height, and there was a lot of severe injury on right side. So that may be the cause of embolism.
I think not very commonly seen apart from the long bone fractures. There has to be some fat embolism coming from the marrow.
Yes, sir.
So, yeah. So I don't know. It's from with only ankle injuries. I haven't seen a case like that.
Yes.
Maybe some prolonged immobilization. It has happened on the second or third day itself, or like
on second post-op day, sir. Second post-op day patient was started desaturating.
Since he had a D10 fracture, could it be some associated injury to the chest which has resulted into this pulmonary complication?
Yes.
Because there was a fracture at a thoracic spine.
Yes, sir.
Yeah. So because of that, probably he also had an associated rib injury or thoracic injury, yes, which was probably cause of the pulmonary embolism.
Yes, sir.
Or ARDS, let's say. Maybe some lung contusion or that. It may not be absolutely fat embolism as such.
Yes, sir.
Yes. Anybody? Any question? Yes, Rahul, what would you say?
He has managed it very well, sir, because primarily the left side was dealt, and for after 5 to 7 days, the right side was dealt when the blisters were gone and the skin condition was operable, because a lot of hardware was really needed to fix that type of fracture. If primarily it was operated, he would have just managed with some shaky job.
Okay, Mandar, your comments?
Sir, I would like to know what was the condition of the talar head and the cartilage of the distal tibia. Was it preserved, injured, and if it is injured, how are you going to manage it?
Cartilage at talus.
Yes, talar head or distal tibial articular
The
surface.
distal articular surface was already disrupted, as it is the anterior more than 30% of the anterior articular cartilage was articular fragment was disrupted. There was a lot of comminution, also metaphyseal comminution. The cartilage condition was not good, but the cartilage of the talus, there must be contusion. As the talus, this mechanism of this injury is the talus forces against the distal part of tibia, that is pylon. That's why it is.
It acts as a
fractured.
mortar and pestle. It acts as a mortar and pestle.
Yeah.
So the talar head, which is talus, is a compact bone,
So it is not
and the
fractured.
tibia lower end is not all that compact. So it rushes into that. I think Dr. Mandar wants to ask you the cartilage status, and was the intra-articular fracture elevated? Did you elevate the tie punch element of the fracture?
Yes, sir, definitely. The impacted articular fragment was elevated.
Yeah. Did you put any bone graft?
No, sir.
Okay. And at this juncture, may I call upon Dinesh to put his comments? Yeah, Girish is back. After Dinesh, Girish, I'm going to request you to comment on the fixation.
Sure, sir. Sorry, I was a little bit disconnected.
Yeah, I was waiting for your arrival. I wanted your comments since you are also a foot and ankle surgeon.
Hello, Vikrant. Actually, yes, this was a very well managed case. I just have one question for this. You had buttressed it anterior plating. Why only one screw in the proximal fragment? Is it sufficient, or are you? What is the recommended?
Actually, it was sufficient for buttressing this thing, and because of the proximal extension of the incision, I avoided that.
Okay. Yes, and this was there was a lot of combination.
Yes, sir.
Definitely, that is agreed.
So just adding to this question, like why can't we put this proper anterolateral plate which is available for such kind of
fractures?
For tibia, anterolateral plate.
Yeah.
Yes, sir. Actually, I want to plate fibula also, and for that matter also. And for anterolateral plate, will not give that much buttression effect to the anterior fracture part. So I avoided that. For anterolateral plate, I have to take anterolateral approach, and again I want to fix the fibula also laterally. So the gap between two incisions, it will be very less. So I avoided that.
Okay. At this juncture, Girish, I have few questions for you to comment.
Vikrant, sir, can we get your post-operative X-ray? Can you please share your screen and
Girish, I want you to comment on approach he had chosen, the plate selection, and then the quality of fixation on right side. And left side, what he has done is he has put a screw to the posterior malleolus. Would it be enough, or should we go ahead and put a posterior buttress plate on left side? So approaches and the quality of fixation and the comment on posterior malleolus.
So in general, if you talk about the approach selection in the tibia pilon fracture, only one thing which is important in the CT scan is the area of comminution. So in the CT scan, axial cut is the most important cut where you decide the approach. Yes, so suppose if you have an anterolateral comminution, that means my anterolateral work is more, I have to go for the anterolateral approach.
Correct.
If the anteromedial comminution is more, posteromedial, posterolateral, same like this. So depending upon the area of comminution, we have to choose the approach, number one. But sometimes we need to choose the two approaches also. For example, you need a posterolateral approach for the fixation of the posterior big posterior malleus, I mean the big chunk and the fibula. So that part is done. At least you have to keep a 5 to 6 centimeter of the gap between two incision. It's a universal law in the ankle, foot and ankle. At least 5 to 6 centimeter. So it means posterolateral, if you have chosen, you cannot choose the anterolateral.
Yes.
Because the size is very different. Either you can go for the dead lateral, a dead anterior, but here you cannot manipulate or you cannot address the anteromedial piece, which was a big fragment here in this case. So if suppose if I am doing this surgery, I would have taken the posterolateral approach for the fixation of the posterior buttress and fibula, and extended dead anterior approach, which with some curve to the anteromedial to address the anterior as well as the anteromedial fragment. Second thing, you are absolutely right that keeping a die punch fragment to the talus is a very difficult task, and fixing it without the bone graft is again a very difficult. But I think Dr. Vikrant sir has done a fantastic job. He got the ankle mortise back, but I am a little bit dissatisfied about the anteromedial reduction. So can we go with the post-operative exercise?
Immediate post-op.
Yeah. So here you can see, sir, this is not a medial malleus fracture. This is basically a posteromedial fragment. Yeah. So there is a go to the CT scan, sir. CT scan.
Yes, yes, sure.
Yeah. So axial cut is very important. Axial. Yeah. So this is basically here we want to see that where I want to do my maximum work. So look at the fibula and look at the big chunk of the posterior malleus. This two fragment you can address with the posterolateral approach.
Okay.
So so that this is how you can build a block over which you have to reconstruct the anterior fragments. Okay. Now, to address the anterolateral, anteromedial, and a big die punch, I think choosing a mid and the direct anterior approach is a wise idea. The only thing is you have to extend the incision because this is the tendon separating approach.
Yes.
So this is how you can address it. But if you go for the post-op X-ray, sir. Yeah. So here the 2 cc screw fixation, I think the rest of the work, fibula, and although he has not fixed the posterior bulb, but that is fine. The anterior buttress is also looking very good. But if you see the anteromedial buttress, look at the talus, it is little bit tilted medially. And if you go with the second X-ray, sir, post-op X-ray, here everything looks good. But if you see this X-ray, the posteromedial chunk is not anatomically reduced. Right. And it is keeping the talus anteromedially. So most of the time, the screw is not sufficient. You need to put a small buttress plate, 2.7
buttress plate would be ideal.
Without even putting a distal screw, you can buttress the posteromedial.
Posteromedial,
the same approach, dead anterior approach. Rest everything is good, sir. You have done a fantastic work.
Thank you, sir. Thank you.
Thank you, Girish. I also wanted you to comment, and for the benefit of viewers, is this only percutaneous screw or only screw fixation is good enough for posterior malleolus, or should we opt for the buttress plate?
Yeah. So for many years, this has been concluded that there are many construct, buttress plate and the screw. So the final conclusion is, if you apply the buttress plate, the stability of the construct is much better, even 3 times stronger than putting just a screw. Second thing, direction of the screw is very important. Suppose if it is not going perpendicular to the fracture, so posterior malleolar fracture, they are always a fracture of the oblique plane. So it is very hard to judge what is my perpendicular axis. And I have seen many of the time it is not possible to pass a screw. So putting a plate is a wise idea. I think it's a less headache to the surgeon. Plus, you can control the full syndesmotic pull with the application of the buttress plate, and it's a very strong construct. So I think even for the small buttress, small fragment to the middle big size fragment, plate fixation buttress plate is a wise idea. Screw, if you are putting only one screw with washer, make sure in the CT scan you are perpendicular to the fracture line, and it should be oblique. It should not be posterior to the anterior screw. It should be obliquely seen on the postoperative exam.
Okay. Vikrant, what is your carry home message for the pylon fractures?
Sir, for the pylon fractures, I want to say that these are a very severe injuries, not only bony, but for soft tissue also. So you should wait till the wrinkles appear, that wrinkle signs appear. You should do these cases in 2 stages. If the swelling is more, or the combination or displacement is more, we can span it first, then you can do CT, and then in second stage fix definitely.
Yes, Vikrant, thank you for a very good carry home message, because the usual principle is span, scan, and plan.
Plan,
yeah?
Yes.
So before definitive fixation, your plan should be perfect. And now with this note, I want to call upon a person who has treated the ankle in a primarily in a different way. So Mandar, are you ready with your presentation?
Yes, sir. Yes, sir.
So Mandar, I request you to start sharing your screen and present your job.
Sure, sir. Thank you. A very good evening to all. And I would like to thank you all MOA dignitaries chairperson on behalf of Ahmednagar Orthopaedic Association. So tonight we will together explore the possibility Tonight we will all explore the possibility of whether can an immediate ankle arthrodesis be a viable approach for severe fracture patterns. So let's see. So this is a history of my patient. He was a 60-year-old male, had a high velocity trauma with comminuted ankle fracture dislocation. He was added with some comorbidities such as uncontrolled diabetes. His HbA1c was around 11.5, and he was undiagnosed at the time when he was presented to us. It was high sugar levels which prompt us to get his HbA1c done. Secondly, he had blisters and severe bruising of the local tissue. So here are his CT images. As everyone can appreciate, there is a good amount of ankle subluxation along with a severe comminution of the lateral malleolus or the distal fibula. Although medial malleolus is a good chunk. So we primarily counsel the patient and tell him that we don't want to operate this patient or operate this fracture on the basis of uncontrolled diabetes and bad local conditions. So we counsel him for a different treatment modality, that is an arthrodesis. So we
Mandar, let me interrupt you. Does anybody from the panel think that this joint can be salvaged?
Yes, sir.
Sure.
If you look that tibio-talar joint, the articular surface of the tibia is very much intact.
Fair enough. What is the option then?
The fibula only.
What is the option in your mind?
Option is to fix fibula in 2 stages. Primarily, go for if it was contaminated wound, go for debridement, K-wire fixation, or a temporary fixator for ankle spanning fixator, and then in second stage for plating of the fibula and middle malleolus.
Where would you put us distal screws? How would you fix the fibula? How would you fix the fibula?
Yes, sir. It is difficult. Very small fragments are there, but anatomical.
Can you span the fibula?
No.
No. Okay. Girish, you have any option in your mind?
Yeah, so sir, this is very comminuted, but I have seen such cases where you can use the anatomical fibular plate
Yes.
so that you can put at least 3 to 4 screw proximal to the fragment and just distal where you see a small fragment. I mean the big low lying fragment. It can hold 2 to 3 2.7 mm screws, but again it is very difficult. You may require intramedullary K wires to maintain the length. But I think only with the external fixator maintaining the length is not possible.
Yes. So you feel the joint could be salvaged?
Yeah. So again, this is a second question that you need to considering the age, uncontrolled sugar. So even if you try everything perfectly for the open reduction interfixation, still there is a 50 to 60% chance of undergoing arthritis. He may land up with some ankle arthritis, maybe 2 years, 3 years down the line, and he may not be able to sustain the second surgery. So here, one of the wise decision may be the primary fusion or the tibio-talocalcaneal nail fusion, considering the uncontrolled sugar and the high chances of going into Charcot.
Okay. Now, Mandar, you please come in picture. What did you do?
Sir, we immediately applied a sugar tongue splint, which was medial to lateral, but subluxation was not correcting and patient was in tremendous pain. So we asked him that we will stabilize it by some percutaneous K wires, and we will just give him a slab and we will wait for the local conditions to fare good enough for the next surgical intervention.
Okay.
And like the same, we said, to avoid the post-traumatic arthritis, pain, stiffness, and possibility of the further surgeries, as mentioned by Dr. Motwani sir, we offered him painless, stable joint with minimal local tissue complications, which he couldn't refuse. So this was immediate post-op, and second one is a 6-month post-op. We applied here the anterior plate, which is obviously in Western world they use anatomically contoured plate, but we don't have it, so we use 3.5 millimeter Ellis plate. So we again propose that arthrodesis is a dish best served cold, and the main indication is that in a non-restorable ankle anatomy. So this is a 3 years follow-up of the patient, and this is his current video. And as we can see, that forefoot is giving some amount of motion to his ankles.
Thank you, Mandar. Really, thank you, Mandar, for a wonderful, wise decision, I'll say.
Nice.
And
yes, sir.
Yes.
And
I really congratulate you for a wonderful and wise decision. Had it been my ankle, I would have definitely preferred the surgery which you yourself chose for this patient, because this is one go surgery. So thank you very much. Are there any questions for Mandar? Everybody is left speechless.
Yeah, Mandar sir.
Yes, sir.
Rather than taking the ankle only, because still there is the good chances of getting the non-union if you just involve the ankle, and also the fixation, you luckily got a very good result, but because I think your preparation and fixation, everything was good from the beginning. But if you see the literature, a diabetic patient's old age, when you have one attempt, it is always better to fix to involve the subtalar joint as well. So you can go for the tibio-talocalcaneal nail fusion as a primary option also.
Yes, sir. Yes, sir.
Was there any evidence of Charcot joint to consider what Girish is saying? See, Girish is suggesting you to go for subtalar joint fusion as well. Had it been Charcot's joint, I would have opted what Girish is saying, because in Charcot's joint, I would go for a global fixation, global orthodesis.
Yes, sir.
So I
Again, the
think
question.
he was not the known case of diabetes. I think first time you guys have detected that he's a diabetic. Is it so?
Patient. Yes, sir. Yes, sir.
Okay.
For the
Again,
benefit of viewers, I would like to put one question. When you perform ankle arthrodesis via screws, which screw you put first? Either lateral or medial?
during the ankle arthrodesis,
During the ankle arthrodesis?
sir, you can put any of the screw. First, you have to fix the talus with the tibia with multiple K wires in the anatomical position which you want. 5-degree dorsiflexion, 10-degree external rotation, no varus valgus, neutral position, and then you have to pass a screw anterolateral, anteromedial. So while tightening the screw, you just have to take care that is there any talar defect. So suppose if there is any medial talar defect while preparation, always put an anterolateral screw first. As long as both the surface are congruent, you can put any of the screws.
Any of the screws. Okay. If at all varus or valgus, what is preferred, varus or valgus?
It should be the neutral, sir, or 5-degree valgus, but varus is a poorly tolerable condition.
Valgus is intolerable. Okay. Does anybody have any question? So I can call
Sir, I
upon
would
the
like to
next
ask one question.
Yes, please go ahead.
Yeah. Like when we are fusing an ankle, is application of a Charnley's compression system rational? We shave the tibia, like the tibial pylon and the talar head, superiorly the talar dome, and remove the medial malleus and morselize the lateral malleus, and then put a pin and then a Charnley's compression device. What is your say about it?
Sir, I personally don't prefer to go ahead with the external fixation in such kind of patients which are diabetic. And secondly, sir, we have a fair good amount of good outcomes associated with anterior platings. And even as sir said, TTC nails like tibio-talocalcaneal nails, these are also giving a fair good amount of results. So I have never performed it and I don't have any knowledge about it, sir. I think Motwani sir should answer the question, sir.
Yeah, I completely agree. Chanley's was the medical college instrument, and nowadays we are moved to the kind of shapy plates, and so people prefer the internal fixation better than the external as long as the injury is closed. I agree.
I think Chanley's is reserved for septic ankles, where internal fixation is avoided.
Yeah, that is right.
And Vikrant sir, in foot and ankle, we have very rarely seen a people putting a Chanley's.
Yes, sir.
Very rarely. Even in the IFAS group,
I belong to an era. I belong to an era. We have done Chanley's clamp and arthrodesis with Chanley's this thing. But currently, I would go for screws and plate fixation, which is much better and much accepted by the patient.
Acceptable condition.
Right. Acceptable to the
patient. Sir, I would like to ask one question, Motwani sir.
Yes, sir.
Yeah, fusing the subtalar joint and not fusing, what difference does it make in a normal gait?
Yeah, so if I am choosing a young patient, say 40-45-year-old, I would prefer to save the subtalar joint if it is not involved, as long as it is not involved, because the subtalar joint, although it is responsible for the eversion and the inversion, which hardly matters, we are walking on the uneven surface, but it is the synergistic joint with the talonavicular. So if you lock the subtalar joint, it reduces the talonavicular movements by 50%, and it reduces the foot flexibility also. So in young patients, I avoid the subtalar, but in the older patient like this, when the stability is more important than the foot mobility, I think going with the subtalar involvement with the tibio-talocalcaneal nail is a good option. I don't care about the loss of inversion and the eversion in a 60-year-old diabetic, less potent patient. But in younger patient, yes, you have to save anyhow.
Lot of
so if subtalar joint is fused, there would be less flexion extension at the foot then. What you say?
Yeah, so flexion and the extension, it happens at the talonavicular joint after fusing ankle and the subtalar.
Okay.
So some of the movements happen at the talonavicular.
So it would be comparatively reduced if we fix the subtalar joint.
Yes, so if you involve the subtalar joint, the talonavicular joint flexibility, adduction, abduction, dorsiflexion, plantar flexion, they all reduces.
Okay, okay, yes.
Dr. Prabhas Patil, you have any question? Unmute yourself, President Sir. Dr. Prabhas.
Hello.
Ashutosh?
Hello.
Dr. Prabhas. Yes.
It's a
I
very nice.
welcome Dr. Prabhas Patil, our President of Ahmednagar Orthopaedic Association.
Very nice presentation by Mandar also and Vikrant also. Just I want to ask one question. Can I ask to Vikrant?
Yes, sir, sure.
You have quoted that you have started partial weight bearing at 8 weeks.
Yes,
How
sir.
you manage that partial weight bearing?
With walker, sir.
Partial weight bearing with
Walker.
Walk.
How is it possible? But no, when we use walker, sir, there part of your weight is given on walker, so you are not weight bearing fully on both ankles.
Does it really work?
Okay.
It's just like bilateral tibia.
Can we try two-touch weight bearing?
Yeah. Okay. Since we are running short of time and I have to take 3 more presentations, I now request, I would stop question and answers on these 2 cases. I request Ashutosh Joshi to please present his case. Ashutosh, are you ready?
Yes, sir. Can you see my screen?
Yes, sir.
Yeah,
Yeah.
very well. Yeah, please go.
Yeah. So after seeing such wonderful foot and ankle cases, let us move proximally. I'm presenting a case of intertrochanteric fracture of femur in a pre-existing avascular necrosis of the femoral head. As we all know, AVN of the femoral head, it can alter the biomechanics of the hip, which can lead to the limping and alteration of the gait pattern. In a weak or frail patient, it may cause loss of balance and fall. Osteosynthesis in such case of hip fractures with pre-existing AVN, it is really difficult job due to altered shape of the femoral head and the sclerotic bone. And in such cases, orthoplasty can be a good option. So my case for today is she's a 50 years old female. She was a known case of SLE, and probably due to long-term steroid, she developed avascular necrosis of the left femoral head, which was diagnosed around 5 to 6 months back, 5 to 6 months before she had a fall. And one day she had a fall and she sustained intertrochanteric fracture of the left femur following a fall at home. So this is our pre-op X-ray, where you can see the comminuted intertrochanteric fracture and AVN of the femoral head. It is involving almost more than 50% area, and there is collapse of the head also. So considering her 50 years old age and these 2 conditions, mainly the choice was between osteosynthesis and orthoplasty. So just for the sake of discussion, the points in this particular case, which was favoring the osteosynthesis, were her age, being a 50-year-old lady, we should always salvage the head, and being an extracapsular fracture, high chances of healing. So these are the factors which was in the favoring osteosynthesis. But the main point or technical consideration against the fixation was the subchondral purchase of the screws. So like in this picture, you can see any implant, the femoral neck screws, it would have a poor subfrontal purchase due to the collapse of the head. So there would have been high chances of failure of the implant. So the other option, the orthoplasty, the main point which was in favor of orthoplasty were basically the two issues we could address them simultaneously. That is the AVN part as well as the fracture part. But again, the main point against it was the longevity. Being a 50-year-old lady, she may require or she will require revision at some point of a time later life. So after thorough counseling of the patient, orthoplasty option was decided. Her pre-op investigations were.
Can I interrupt here? Yeah. Can I ask one question here? Yeah.
Yeah, please go ahead.
Was she symptomatic for AVN before, and was she having any limp, or will that make any decision change? Means if she was happy before with whatever AVN she was having, will it change your option?
No, basically she was symptomatic and she was advised joint replacement by other surgeon beforehand also, but she was just prolonging it due to some other reason, and she had limping and pain on that side. So apart from the symptoms, with such kind of collapse, I don't think the fixation would be a good option for this.
Okay.
Okay.
So apart from an anemic status and hyperproteinemia, other blood investigations were fairly normal considering her SLE status. Even her 2D echo were also normal. So left side total hip replacement was done through the posterior approach. I used a dual mobility cup and a distal fixing long stem for the femur. There were quite a few challenges compared to the routine case of the THR in this particular one. The first one I encountered was while usually before dislocating head, when we cut the rotators near its insertion, usually internal rotation by an assistant, it makes the rotator taut and we can cut it near its insertion. But in this case, since the GT fragment was fractured, I had to ask my assistant to pull that fragment laterally so I could see that, so that I could see the rotators insertion and I could cut them near their insertion. The second one was surprisingly due to fracture GT part, I could see the anterior acetabulum better compared to the routine case where we really have to put pressure with your anterior spike to see the anterior wall of that acetabulum while reaming. So in this case, it was a boon since the GT fragment was fractured. Routine parameters were based on which we assess the stem version. They were absent. Like, there were no calcar as well as the LT fragment was also fractured. So only reference for my femoral version was the vertical tibial axis. And same thing is for the limb length assessment, the vertical offset also. Usually, like many of us put some two reference points, one above the acetabulum and one below, and we try to replicate that after putting our trial implant. But in this case, since it was a fracture of the neck, these bony landmarks were not available intraoperatively. So only thing I had to rely on the compared with the opposite side of the leg. So this is my immediate post-op X-ray. I put a dual mobility cup, cemented cup I had to put. I didn't get a good purchase with uncemented cup. And distal fixing long stem. And the GT comminuted fragments, they were reconstructed with the SS wire. And this is her recent 2 years follow-up X-ray, where you could see implant in similar position. Incidentally, there are changes of AVN on the opposite side also, but right now she is not symptomatic on the opposite side. And this is her recent video. I could find the case series report in Chinese Trauma Journal where they presented 6 cases of say IT fracture with the pre-existing SLE, mainly pre-existing arthritis of the hip involving primary OA of hip as well as AVN. And they mentioned same thing, that treatment with the joint replacement is better to address both the issues. So I would like to summarize, but THR is an excellent treatment modality for intertrochanteric fracture of the femur with pre-existing AVN of the femoral head. Main advantage is it addresses both the issues simultaneously. Intraoperatively assessing stem version and offset, they can be challenging. Your routine landmarks may not be there or they are not reliable. Since calcar is absent, we need to use the distal fixing long femoral stem. And dual mobility cup is an advantage, especially in any trauma scenario, mainly to decrease the dislocation rate. Thank you.
Thank you, Ashutosh. I myself have a couple of questions.
Yes.
As you rightly said, the chances of dislocation are less with dual mobility. It is a forgiving implant.
Yeah.
But was the acetabulum insufficient? What made you to choose? Why did you suspect dislocation in this case?
No, I am saying
Chances of
comparing with the
dislocation,
routine. When in any trauma scenario, when the proximal femur soft tissues are affected, like your rotators or in this case even the GT fragment. So they early studies, it's not a long-term study with the invent of dual mobility, that the dislocation is less compared to the routine unipolar THR, even if you use a large size femoral head.
Okay. Yes, Dinesh, you have any question?
No, sir.
Okay. Rahul, any question?
Was like she is a young female. THR
No.
definitely
Wait.
was a
Yeah.
THR definitely was a choice, option of choice. Like
Just wanted to ask one question, like, the patient was on the chronic steroid for a long time now. So do you make any changes in a steroid protocol, or are there any more chances of infection in such patients because they will not stop their steroids ahead? Any antibiotic, more prophylaxis you give, or the chances for infection ahead?
No, in fact, when long-term steroid patient is taking, there is chances of insufficiency if you suddenly stop that steroid. So either you need to taper that steroid, and sometimes, in fact, intraoperatively you just have to supplement that even intravenous some hydrocort or dexamethasone.
Absolutely.
And afterwards you just need to taper. But since her SLE status is not controlled very well, so she was asked by rheumatologist to control with even after surgery with low dose of steroids.
Okay.
During surgery, actually, you should not taper those steroids. Actually, you
Yeah,
should
in
have
fact,
a
you
better
need to
control of
maintain that dose and in fact supplement that.
either rheumatoid or all these autoimmune disorders for that matter.
Yeah.
Did you put her on any other bone forming like alendronates, teriparatide, etc.?
No, actually, because I told her to consult a rheumatologist afterwards, but since the COVID scenario, she is not able to consult rheumatologist in Pune. So she's planning to go maybe this month.
And what made you to choose cemented components in this case?
No, actually, I had planned uncemented one, but probably due to soft bone or maybe I could not get a good hold of that uncemented cup. So it was sort of a salvage last. I initially started with reaming and planning was to use a uncemented cup.
So what are your tips and tricks for selecting the version in these cases?
Especially when your calcar is absent and your distal fixation stem you are going to use. Though, as I said, only available reference point is probably your vertical Steven stage. Usually in trauma scenario, I try to put a more version on the stem, since the stems distally are cylindrical. So you just have to maintain that version while putting the trial stem or the final one. And probably the epicondylar axis theoretically is mentioned from which you can control that version, but more practical is the vertical tibial axis.
Okay. Anybody has any question? So good solution, Ashutosh, for 2 diseases and 1 surgery. So with this, I request Dr. Dinesh Patole to come ahead and start his presentation.
Just a minute. Good evening, everybody. Am I audible?
Yeah.
Good evening, everybody. First of all, I would like to thank all the dignitaries of Maharashtra Orthopaedic Association for giving me this opportunity. I'm Dr. Dinesh Patole, practicing in Ahmednagar. I'm presenting a case today. Actually, I couldn't find a case of transverse fracture of acetabulum. So I beg your pardon and apologies. So that I'm presenting a case of posterior wall fracture, and it has a very good follow-up of 2 years almost. This was a just an outset. Posterior wall fractures are very common injuries and the most common injuries of the acetabulum. But they can have a very poor outcome if not managed adequately. There was classification by Luternal and Jude for this specific fracture, posterior wall fracture, depending upon the fragment combination. Posterior wall. Type 1, we have only single posterior fragment. In type 2, we have multiple fragments, more than 2 fragments. And in type 3, we have impacted fragment, can be associated with a single fragment or multiple fragments with a condyle injury. So I'll start my case. It was basically a 20-year-old male. He came with history of RTA. Patient, when he came to the emergency room, he was hemodynamically stable, but he had a fracture dislocation of the left hip. Associated injury, there was no chest or other injuries, head injury or abdominal injury, but he had a radius ulnar fracture on the opposite side. So very sorry again. Actually, I don't have immediate X-rays, dislocated X-rays. I only have the CT post-reduction. So in emergency room, we stabilized the patient, and then we took him for immediate reduction under short GA. It was done before 12 hours maybe. Then we put him on skeletal traction and sprinting for radius ulnar. Fracture was done. After reduction, we sent him for the CT to see what all we have in front of us. So there was a comminuted posterior wall fracture of the acetabulum, left acetabulum. As you can see on the CT, if it's visible properly. These are the axial and sagittal coronal cuts of the CT. We had a concentric reduction. There was definitely a combination of the posterior wall. Luckily, there was no incarcerated fragment or no impaction injury in this case. So it was a good case for a beginner to start with. Treatment options, what we just for discussion purpose, either a non-operative or an operative. I went for an operative just for these indications because it was more than 50% of the posterior wall was involved. Almost 70-80% of the posterior wall was involved. There was fracture. He was a young patient and the hip was unstable to start with. So so the goal of our
Dinesh, I would interrupt you for a minute.
Yes, sure.
What are your options for non-operative management of posterior wall?
Sir, non-operative management in young patient only skeletal traction, in abduction and external rotation. Actually, the position what they say is it's basically has to be abduction and external rotation. In elderly, we can try it if it is stable. Hello.
No. How do you select that this case needs a conservative management or you would go for surgery?
Sir, very good question. Actually, I just said the most important indication is the stability. Intra-op stability, you can assess by stress views or stress fluoroscopy examination under anesthesia. If it is stable hip in internal rotation and adduction, you can go ahead with conservative treatment. In that case, you will have less than 20% of the posterior wall involved.
Okay.
In that case, you can always go for, if the hip is stable, you can always conserve it. You can go for a non-operative treatment. But if it is more than 50%, there is no other option because hip is unstable and it is going to dislocate and it is going to go in AVN. So our only option is anatomic reduction and stable fixation in this case.
Yeah. Sometimes here I wanted to add that you do a close reduction.
Yeah.
You can see for the stability in all directions. And sometimes if you feel it is not stable, because if you already got the previous X-ray, so simultaneously going for open reduction in the same sitting is nowadays recommended. Not to give anesthesia for 2 times if feasible for your setup.
Yeah.
And that too, in what part of the day you are doing it. If you are doing it in the night hours, I would recommend that you go ahead with only reduction and plan fixation at a later time.
No, one more thing, I would we don't have pre-op CTs during that time, so only we will be able to check only the stability of the hip. We won't be able to check how much is the comminution, how hello.
So you mean to say the ideal plan would be reduce scan
definitely,
and then plan.
Yeah.
Okay.
No, when we reduce, we'll always check for the stability. Means we all do. I think
very
so.
True.
We always check for the stability. So the goal of my treatment was actually in any orthopedic surgery, we always aim for the normal function of the affected musculoskeletal structure. In this case, it was in hip. So anatomic reduction and stable fixation is the dictum for any joint. So my operative plan, how to go about. First, optimization of the patient, do his blood workup, arrange blood for this patient. Timing of surgery was more important. Timing of surgery in this case with fracture dislocation, it has to be before 2 to 3 days, maybe after immediate reduction. Immediate reduction is within 24 hours, and then we can plan and go in with not much of soft tissue injury in this. We can go in before 3 days. Position. Actually, I prefer lateral position because
and
I was
then Dinesh, if you miss that time slot 2 to 3 days,
we can always go. We can always go before for 2 weeks. Before 2 weeks, it is soft tissue planes and this thing we can dissect, and it is amenable for stabilization and fixation.
Okay, fine.
The position, I usually prefer lateral, but prone position is much more easier according to other surgeons, but I have never done it because it assists in reduction, gravity assists in reduction, and fixation becomes very much easy. In lateral position, it's just somebody has to give lateral traction as well as extra traction. In the lateral position, one thing you should always maintain is knee flexion to avoid stretch on the sciatic nerve. Luckily, pre-op and even after post-reduction, he did not have any neurological injury, any neural deficit. So approach, we don't have much option. We only had Pahukar approach here. And armamentarium, nowadays we have pelvis set. And in this case, since there was a comminution, we also kept spring plates ready. Spring plates, basically what we did was just 130 below plate, cut it at the hole and use it as a spring plate. Timing of surgery, we could do it just 5 days after the initial trauma because of other issues. Position, lateral, and approach, as I just already told, it was Pahukar approach. Difficulties which I was going to face was fixation of the small fragments. If they don't have any soft tissue injuries, I would have had to excise it, and preservation of their vascularity of these small fragments and the vascularity of the head of the femur was very important. Since it's just there where we differ with arthroplasty and reconstruction surgery or preservation, head preservation surgery, hip preservation surgery. Here you have to preserve the vascularity of the small fragment as well as femoral head. Here we don't incise the insertion of all the external rotators. We can preserve quadratus femoris here.
Correct.
Because the vascularity of middle circumflex femoral artery just beneath the quadratus femoris. Just 2 steps about two slides about Pahukar approach. It's curved incision. Actually, split the gluteus maximus in the line of the fibers. What we incise the external rotators, gemella and obturator internus, just at the insertion. Develop a plane. Exactly what we do is develop a plane between external rotators and capsule. So we don't incise capsule and external rotator at one go. We always mark quadratus femoris has to be identified and
preserved.
Definitely. Thank you, sir. Then we here, since there was a fracture of the posterior wall, we did not do a capsulotomy because it was already done like a there was a fragment attached with a capsule. Luckily, it was attached to the capsule, so I could preserve its soft tissue. And this was very sorry again. I did not have pre-op X-rays. This was an immediate post-op X-ray where there was a concentric reduction and stabilized this thing. It was stabilized. The bigger fragment was stabilized with cancellous screw, and then it was buttressed with a pre-contoured plate. No, sorry. It was not a pre-contoured plate. We contoured it over the table with a plate bender. This was in 2020. I don't have Jude view immediate post-op, but I have recent 20 months follow Jude view as well for our assessment. This was 20 months follow. These are the Jude view for the same 20 months post-op.
Thank you. Yeah.
Just I would like to share this video. Just a minute, sir. Just a minute. I will. Very sorry, not very much tech savvy. This was his. There was no limb on walking. Thank you all. Hello. Hello.
Yes, Dinesh.
Thank you.
Manoj,
Thank you.
Manoj, yes, Manoj, you have any question for Dinesh?
I think he had done a wonderful job. He could get the results very well.
Yeah.
It's an ideal standard treatment which he follow that for that particular case here.
Thank you, sir.
Thank you, Dinesh. Done
Thank you,
wonderfully, presented wonderfully, and I'm sure there are no questions.
Thank you, sir. So nice of you.
And I hope you have done axial traction, put the stand spin, and done everything, whatever has to be done.
Steps
All
I
the
did not
steps
describe.
have been followed. Yeah. And thank you for elaborating the difference between a standard posterolateral approach and the Cocker-Langan diagram.
Cocker-Langan diagram.
Yes, thank you
Yes,
very
you
much.
already guided me. Thank you, sir.
Yes.
Thank you for that.
Prakash, you have any question, Dr. Prakash Shekadar? Okay, fine.
Sir, I have one question, sir.
Yes, sir, go ahead.
Yes. Sir.
Chances of avascular necrosis in this case, how much you expect, and how will you assess, means with MRI or anything? And third question is implant. Which implant do you use of metal, SS or titanium?
Yeah, I use SS implant actually. Means it's definitely it is a ferromagnetic substance, so it will just have artifacts. It is not an absolute contraindication for MRI. You just have artifact, and you can always assess for vascularity, or you can always means know even in early stages. That's not an issue with the implant. I think so.
For that matter, nobody uses titanium plates for pelvis. Because the malleability is less.
Yeah.
And in pelvis, we need malleable plates.
Malleable and strength. Yeah, definitely. Yeah. And sir, avian predictive factors for avian is actually the combination and the timing of reduction and stabilization. There was a study by, actually I just went through some studies. Actually there was a study by studies by Raphael in 2017. He showed that early reduction and anatomic reduction are the only factors which have say in post-op avian. And these are the factors which govern.
Yeah.
Actually, we are running short of time, but there are a lot of things which can be discussed. And since I want to stick to the time, I now close the discussion on this fracture pelvis or fracture posterior wall. I call upon Dr. Rahul Pandit, who is secretary, who is a very dynamic secretary, and I want Dr. Rahul to present his presentation. And Rahul, please be specific and please be in time.
Yes, sir. Good evening, everybody. First of all, I am thankful to Maharashtra Orthopaedic Association, Gadegone sir, his brainchild of Young Surgeons Forum, and all the MOA dignitaries, and our PN sir for giving us an opportunity. Today, I am going to present a case on fracture L3, where I am going to do a short segment. Well, I am going to present a short segment fixation. I'll just share my screen. So I can't share my screen actually. Hello? Sir, my screen is not, I'm not able to share my screen.
Poonam,
Manoj,
from OrthoTV, can anybody help?
Like, can you see what is seen here?
No. You stop sharing your screen and do it again, I suppose. Stop sharing. Open the PPT presentation.
Dinesh, have you stopped your sharing?
Yes, sir. Yeah.
Rahul, open your presentation and minimize it, and then again start.
Where should I open my presentation?
Easy. पहिले तुझ्या डेस्कटॉपवर ओपन कर अगोदर.
Okay.
शेअर करूच नको सध्या. आणि ते ओपन झालं की मग त्याला मिनिमाइज.
ओके.
आणि नंतर आता शेअर कर, मग ते लगेच तुला दिसेल तुझं.
हा, आता दिसतंय. नाही, आता माझं आय कॅन सी माय इमेज.
आता क्लिक कर ना त्याच्यावर, मग शेअर स्क्रीन करून त्याच्यावर क्लिक कर.
Select the window, the window you wanted to have that PPT.
जे प्रेझेंटेशन आहे ते क्लिक कर.
Yes, I could get it.
मिनिमाइज
Thank you.
केलेलं जे आहे ना.
Ha. Got it. Yes. Now is my screen visible to everybody?
Yes.
होतंय, स्टार्ट होतंय. Yes.
Okay.
फुल स्क्रीन कर त्याला, फुल स्क्रीन.
Okay. Slide show.
Yeah. Full screen है, show slides.
अच्छा, this is not the full screen.
राहुल सर, ते डावीकडे फ्रॉम बिगिनिंग आहे तिथे करा. राहुल सर,
Slide show
फ्रॉम बिगिनिंग.
Okay, yeah. Okay, thank you. So I'll be presenting a case of compression L3 fracture with short segment fixation. We had a patient, a 35-year male patient. He had an history of RTA. Yeah.
Rahul, तुझा screen
दिसत नाही.
Rahul, you had the same problem while we had rehearsal of our presentation.
Have you made it the full screen?
आता जसं
Show the next slide. Show the next slide. Yes.
Yeah.
Yes.
You present in this view only. Don't make it full screen.
Okay.
Scroll
No
down.
problem.
Yeah.
So we had a patient, aged 35 years, patient. He had a history of RTA and was present in the casualty with severe backache. He had tingling, numbness in lower limbs and weakness in ankle dorsiflexion and plantar flexion. EHL and FHL were grade 4 in power, and he had an hypostasia of the foot. Now we examined him. He was hemodynamically stable. Relevant X-rays and blood investigations were done. Patient had an associated chest injury, but his saturation was okay. Then we did an X-ray, and we found that on the X-ray he had a L3 compression fracture with a fragment. It was a burst type of fracture. And then we did his chest X-ray. It was normal. Analgesics were given. 1 gram of methylprednisolone was given to him, and patient was shifted to MRI with a lumbar corset belt. We did his MRI, and on MRI we could find that there was a L3 compression fracture and a fragment was retropulsed and it was compressing the dural sac and the exiting nerve roots. This was the axial picture and sorry, I'll just go back. This was the sagittal and this was the axial picture. Then looking at the MRI and the presentation of the patient, we thought that we should plan for a decompression and fixation of the lumbar spine. As it was a L3 fracture, it is a mobile, the mobility is definitely a point of concern. So we can have either a short segment fixation or a long segment fixation. Generally, a long segment fixation is a fixation where two vertebrae up and two vertebrae down are fused and the fracture vertebra is left alone, where we don't instrument it and just do a laminectomy. Along with the laminectomy, we can reinsert the retropulsed fragment by just retracting the dura. And the other option was a short segment fixation, where we just put two screws in the above vertebra, that is the L3, L2, and two screws in the below vertebra, L4. At the same time, we also put an intermediate screw in the fracture fragment. Putting a screw in the fracture fragment will always help. It will increase the stability of the construct and the healing of the fracture goes very well and the chances of collapse are definitely reduced. So we planned a short segment fixation. Regarding the surgery, we explained the relatives regarding what type of surgery we are doing, what are the chances of recovery, like neurological recovery, and then we prepared the OT. We generally operate these type of cases in general anesthesia. A lot of patients think of operating under spinal also, but I prefer a general anesthesia because the relaxation is good and retraction of muscles is always better. So the position patient is prone in position, and before taking the incision, we take a Siam shoot in the lateral so that we confirm what type of exactly where we are going to operate. Because in short segment fixation, we plan to keep the incision minimum, and definitely soft tissue handling, length of the incision will also be also matter if we use an Siam. Now this was an intra-op image where we could put three screws on one side and two screws on the other side. This is also an intra-op image where we can see a laminectomy is done at the central point, and above and below we have preserved the spinous processes. We used a 5-screw construct, one screw, middle screw in the fracture vertebra. Generally, while putting the screw in the middle vertebra, we always think that the fracture vertebra should be used to pass the screw. It seems difficult to pass a screw in the fracture vertebra because the pedicle also is fractured. But if an anatomy if we think of anatomy, like we use the transverse process, then and also the Siam guidance, it is not difficult to put a screw in a fractured pedicle. We by and large as a rule do a decompression laminectomy, and the bone which we have removed is always used as a bone graft, which we put below the connecting rods, so that it also helps and aids in healing. And definitely putting a bone graft at the fractured pedicle or the fractured area definitely heals in a better way. Now these are the images where I have shown a small a punch. I use a punch to insert the retropulse fragment anteriorly, and after the adequate decompression is done, we check by putting a dural retractor superiorly and inferiorly. And in our case, there were no dural tears, and even the accidentally also there was no dural tear. We placed Abgel over it and closed the wound in layers. This was the post-op X-ray where we could put 3 screws on one side, 2 screws on another side. Now the post-op protocol was on the second day we could make the patient stand on the third day, we could make him walk with a support of walker, because this patient had a neurological involvement. So immediately without a walker, I will prefer not to walk him. So using a walker is a better option. Drain was removed on the third day. Physiotherapy was started on the second day. Physiotherapy involves ankle foot exercises, quadricep exercise, bed rolling, and sutures were removed on the 15th day. We generally discharge this type of patients after the fourth day. We have a follow-up after 6 weeks, 12 weeks, 6 months, and 1 year. So the patient did very well. After the follow-up, when he came after 6 months, I could make him sit, squat, bend forward, bend backward. This was after 1 year. We could take his clinical photographs, and we could see he could bend forward, posteriorly, sit and squat. So patient was absolutely comfortable doing all regular routine activities, and follow-up X-rays also showed no obvious collapse. There was some increase in the kyphus angle, definitely, but there was no screw breakout and screw back out. Now I'll just highlight short segment fixation versus long segment fixation, where I generally use a short segment fixation. The reason is the operative time definitely is less, because we need to put just 5 screws. Uh, Many a times I also don't hesitate to put 6 screws in this type of fractures. Adding 6 screws, I feel gives a better construct, two in the fracture vertebra, but passing a 1 screw compared with 2 screws have an equal result. The other thing is the incision. Incision is definitely small. There is less blood loss. Anesthesia time is less. Healing is definitely better in a short segment fixation. Hardware problems definitely are less, because more the number of screws, more chances of screw back out, more chances of screw cut out. Mobility and dynamics are definitely improved because less motion segments are involved. So a person will have a good mobility in terms of flexion, extension, and rotations. Chances of implant failure and infection are less, and definitely the cost of putting less screws is better. On the also, we don't compromise in terms of the results, because we have papers which show that short segments fixation versus long segment pedicular screw fixation in thoracolumbar as well as lumbar vertebrae are equally good. They have comparatively good results, and the follow-up kyphus angle is reduced minimally in short segment fixation, but it doesn't matter the compliance of the patient in terms of his flexion, extension, rotations. And definitely these are 2 to 3 papers which I have highlighted, where a biomechanical comparison of short segment fixation and long segment fixation was done. A lot of people don't put a screw in the fractured vertebra. There is a paper where putting a screw versus not putting a screw in a fractured vertebra was seen. But definitely adding a screw in a fractured vertebra increase the chances of fusion, healing, and the biomechanics are improved. The kyphus angle in post-op protocol, post-op X-rays, uh, if we add a screw, the chances of kyphus angle reduction is less. So this is my paper regarding.
Thank you, Rahul. I have a couple of questions actually.
Yes, sir.
See, in fractures, you always go for a longer plate.
Yeah, definitely.
Yes.
Yes.
So, do you agree that long segment fixation is mechanically, biomechanically more stable than a short segment fixation? If you
Yes, sir.
apply a
Yeah.
logic,
Yeah.
long segment fixation has to be more stable.
Yes, sir.
And the,
If we compare a fracture with a long segment fixation, there is hardly any mobility at the fracture or a bone. Like if we compare it with a femur, the mobility is at the knee joint, hip joint. But in a spine, the mobility is at individual joints. So if we put a long segment fixation, the implant load is more, because more levels are fused. the load on the implant is definitely moving spine. If we are using, say, 4
Long
levels,
segment fixation.
5 levels. Yeah. In short segment, the load on the implant is reduced because there are 2 levels free which are ready to work.
In fracture, you use polyaxial screws
Yeah,
in
definitely.
fractured vertebra.
Yes, sir. Polyaxial screws are used.
Okay. So thank you, Rahul, for a wonderful presentation. Anybody has any question?
Hello, Rahul sir.
Yes, sir.
Excellent presentation, sir. I want to ask about you are using bone grafts as for fusion. So you
Yes.
are putting it on transverse procession as well as on facet joint also.
Yeah.
So
Yes.
are you excising the capsule of facet joint and decorticating it?
No. At the fracture site. At the fracture site.
Okay.
Hello.
So in
Say
your
it's an
presentation, you told
L3
that
fracture.
you are putting it on facet also.
Are you putting it on the facets or you're putting into the vertebral body? Rahul, please be specific. Mandar, your views?
Sir, I think in these kind of fractures, we need to address three issues. The first is, if I can remember, the first thing is that we have to reduce the interpedicular distance. So no matter long segment or short segment, anything you choose, you should be able to decrease the interpedicular distance, which is the foremost criteria of the burst fracture, number one. Second, we'll have to restore the vertebral height at least 50 to 60% as compared to previous combination. And third and foremost thing is the forces which we are applying posteriorly, whether it is compressive force or destructive force. It depends upon the integrity of the posterior soft tissue structures, such as interspinous process fracture, interspinous process rupture, or anything else. And the fourth point is that if what is the amount of retropulse fragment is there. While we are putting pedicle screws in a fractured fragment, it is like doing indirect reduction of the retropulse fragment. So not necessarily we need to always do laminectomy and reduce it properly. Many of the papers shows that it remodels on its own. And secondly, about the fusion, if we are not doing laminectomy, we just shingle out the posterior surfaces of the spinous processes and put bone graft, take out the bone graft locally and put it on the posterior aspect only. There are no
You
need.
mean along the side of the interspinous ligament?
Yes, sir. Yes, sir. Yes, sir.
On the posterior aspect.
Fusion. Yes, sir.
Without denuding the joints, without
Without
incising
denuding,
or
without denuding the joint, it doesn't require at all. It is just a fracture segment fixation, and fusion is not necessary in many cases.
Okay. Manoj, I request you to conclude.
I
On
think,
behalf of Dr. Gadegone, Dr. Gadegone is not there in the scene at all. So
he is traveling. He has conveyed the same thing. Yeah. So on behalf of YSF, I certainly would like to congratulate this the Ahmednagar Orthopaedic Association for all wonderful and excellent crisp presentation. Everybody were within proper time. All the cases were very informative. They do have got the very good take-home messages at the end, and everybody presented very well. I must congratulate all the speakers for this today's session, and I must thank Dr. N Deshpande especially for moderating and conducting this session very well. And I must thank also the OrthoTV for giving this opportunity. Now I will hand it over to Dr. N Deshpande, sir, for his final concluding remarks for this session.
yeah, after I speak, I am going to invite Dr. Prabhas Patil to deliver vote of thanks. I congratulate, I thank all my teammates. And as I said, our young orthopedic surgeons are really dynamic. They are very knowledgeable and they have done excellent job. And I'm really thankful to them. And here I take the opportunity to invite Dr. Prabhas Patil, our president, to deliver vote of thanks.
I am very much on the behalf of Ahmednagar Orthopaedic Association, very thankful to Maharashtra Orthopaedic Association dignitaries, Dr. Gadegone sir, Dr. Karne sir, Dr. Manoj Pahukar sir, Dr. Motwani sir, and all our eminent young dynamic speakers from Ahmednagar. They are really presented very well presentation. They really focus on many aspects, and within a time, with the help of Dr. Vihen sir, they have moderated this very good presentation. I also thankful to Dr. Vihen sir also. Yes, thank you everyone. Good night.
Yeah. Thank you.
Thank you.
Thank you, sir. It was
Thank you,
wonderful
everybody.
time.
Yeah, it was an excellent.
I just lost my access, so could not give answers properly after my.
Thank you, Poonam, for being really a special host, and convey our thanks and regards to Neeraj and Ashok.
Thank you so much, sir.
Thank you very much. Have a good night.
Yes.
Good night, everyone.
Have a wonderful night.
Good night. Good night.
Thank you very much.
everyone.
Good night. Good night,
Thank
Manoj.
you, sir.
Thank you for the opportunity.
Yeah. Thank you, sir. Thank you, everyone, again. Yeah.
Vihen sir, धन्यवाद.
धन्यवाद. धन्यवाद.
मी
Everybody
आहे
धन्यवाद.
महाबळेश्वर.
काय?
मी महाबळेश्वर मध्ये.